Welcome to everyone to this live session of our show Sugar Smart on managing diabetes during pregnancy. I'm your host Shabnam Sengupta and I'm very happy to be here with you all today. Pregnancy, as people say, is a very beautiful journey filled with expectations, happiness, and looking forward to a beautiful future, right? But having diabetes can make it challenging more than a pregnancy can be already, right? So in this session, we will be discussing the impact of diabetes on a pregnancy and how pregnant women and people around them can help these pregnant women to navigate this journey healthily while managing diabetes. So इस इम्पॉर्टेंट टॉपिक पे बात करने के लिए आज हमारे साथ डॉक्टर दिलीप गुडे जुड़ रहे हैं at Yashoda Hospital in Hyderabad. With over 17 years of experience, his expertise lies in internal medicine, diabetology, rheumatology, medical bariatrics, and intensive care. So I have invited him. Wait. Hello, Dr. Gray. How are you?
Good. How are you?
I'm fine. So I've already introduced you to our viewers. So by the way, we are very thrilled to have you again for another show. Shall we start?
Yes.
Okay. So viewers, for you, if you have any questions around diabetes and, managing diabetes during pregnancy, please feel free to put your questions in the comments. Once I'm done with my questions, I'll pick up yours. So how can diabetes impact a pregnancy? What are the potential risks and complications associated with diabetes during pregnancy?
Yeah. So basically, it is very important, in fact, for a tighter control of sugar in a pregnant diabetic patient. So there are 2-3 types of diabetes. I mean, people who have been a diabetic already and who got pregnant. That is one scenario. The other one is people who weren't diabetic before, but they are told that they have diabetes now. As in, that is. So gestational diabetes is something where during pregnancy, people have understood that their sugar levels are on the higher side. So gestational, as in the term itself says that this particular female is now a diabetic, probably maybe a diabetic for the rest of the pregnancy, but usually after pregnancy, after they deliver, they're not going to be diabetic usually. But then there are people who have developed gestational diabetes, that is diabetes in pregnancy, but then even after delivery, some of them, probably like 10-20% of them, may remain a diabetic. So in whatever the scenario, either those who have been a diabetic and got pregnant now, or those who have become diabetic, as in who have become a gestational diabetic, then in whatever the scenario, it is really important to have a very tight fasting and post-lunch control. That is, in fact, there are criteria. Carpenter's criteria is one of the criteria where worldwide, we have to have fasting blood sugar not beyond 100. 90 to 100 is what you target fasting blood sugar. And then postprandial, after food, you cannot allow the sugar to go beyond 150, 160. So this tight sugar control will ensure that there are not many complications that arise just because one becomes a diabetic in pregnancy. Now, what are the complications when people are diabetic and when they don't have good control of sugar during pregnancy, especially during the first trimester or so? So it is a condition that affects both the mom, the mother, and the fetus as well. So fetal babies are known to have complications. I mean, large baby syndrome, macrosome. Pregnancy. So basically, there is an increase in body weight.
Sorry,
go ahead.
We missed you. There was a break actually. Your video was broken. Yeah.
Sure. So just to reiterate, we need to have a very tight sugar control in pregnant females. Fasting cannot be beyond 100. then post lunch, after food, or any time during the day in the 24 hours, we cannot allow the sugar to be beyond 150 or 160. Now, if you don't do that, if you allow sugars to be on the higher side, you're going to have a large baby, as in the body, the weight of the baby is going to be more, probably 3.5 kgs, 4 kgs or more. Because the baby is on the heavier side, there are going to be complications during delivery, during labor as well. There can be increased blood pressure, and then pregnancy-induced hypertension. PIH is also one complication when they have large babies, and when diabetes itself can complicate hypertension during pregnancy. And then the delivery can be problematic because there can be shoulder dystocia. It is a condition where there is difficulty delivering the baby during labor if the pregnant female is not undergoing a normal delivery. Of course, C-section, during C-section also there can be complications. So the ultimate goal is that we have tight, fantastic sugar control. Now, what does it take to have a tight control, especially in diabetic patients? Because probably 9 out of 10 anti-diabetic drugs are contraindicated in pregnancy. That which are safer during diabetes, if there is no pregnancy, most of them are not to be used because there are so many complications that are known to occur in patients who are diabetic, and then you give a drug that you normally give for other diabetic adult patients. So what are the drugs that which are safe during pregnancy for having good sugar control? We only have 2 options here. We have insulin and metformin. And of course, the dose of metformin, it depends on body weight of patients, and you can't really exceed 1.5 to 2 grams of metformin during pregnancy. But insulin remains the gold standard or mainstay of treatment for sugar control in a diabetic pregnant female. Now, how do you do that? I mean, there are some patients where you can give a long-acting once daily insulin, which will make sure there are no fluctuations, as in the both intraday and interday variations in the sugar cannot be more. And then one-time long-acting can help in some patients, but in others you will probably have to give twice, as in a combination of short and long-acting in the morning, and a similar dose or probably a little lesser dose in the night. So insulin remains the gold standard, and then the type of insulin may change depending on the patient's blood sugars, the body weight, and you can do a thing called CGM, continuous glucose monitoring, where sugars are checked every minute for 2 weeks. For 14-day period, there is a sticker like a patch that is placed on the skin, which will keep testing sugar non-stop, and then it gives a reading. I mean, any Bluetooth-enabled device, like even a mobile phone, you can get a continuous monitoring of sugars. At what time are the sugars falling? Because hypoglycemia is even a dangerous thing, even in pregnancy. We can't allow sugars to fall. Neither can you allow sugars to go beyond 150, 160. So these are various things that we need to keep in mind. You cannot allow fasting or post-lunch to be beyond this the goals that I discussed. And then the type of drugs that are available, which are only 2 types. There's one, we have oral metformin on one side, and then insulin. Of course, there are 2 different types of insulin that one can use during pregnancy, but the ultimate goal remains the same. And one most important pillar of management will continue to be a diet. What kind of diet is the patient on? And of course, to some degree, exercise is important. Exercise will help sugars be in control. And of course, there is a misconception that pregnant females should not exercise and all, but they should exercise in a milder, moderate manner. They should not over-exercise, over-exert themselves. There should be some degree of physical activity, unless the obstetrician warns of if there was previous recurrent abortions, and if there are some issues in that case, maybe some exercise needs to be milder, but some degree of walking, cardio must be done, because it is really important. It is one of the pillars of sugar management in a pregnant female.
Okay, so as you said that there can be like diabetes, if not handled properly, can be problematic for even the baby. So can the symptoms of diabetes transfer to the baby from the mother?
No, not really. But then there are some complications that can occur after delivery in a diabetic pregnant female. As in, after delivery, if say the mother has taken some amount of insulin, that insulin can actually, through placental circulation, can reach the baby. Baby can get hypoglycemia sometimes. But usually, if you're giving a long-acting, lesser dose, then that should not be a major problem. But diabetes per se, as a disease, is not transmitted to the baby at all.
Okay. So this whatever we spoke already is about women who are already pregnant, right? So what are the key considerations for women with diabetes, who already have diabetes? So while planning a pregnancy, or while planning to conceive,
so
how can
the moment
they prepare?
any diabetic female understands that she is pregnant, she will need to stop the whatever pre-existing medicines that she's on. Most of the medicines are contraindicated except metformin. In fact, every other oral antidiabetic is not to be given in pregnancy. And of course, they need to get help from both gynecologist and obstetrician on one side, and physician diabetologist on the other side. So the moment she understands, then there's a lot of counseling that needs to be done, both by obstetricians and physicians, where more intense control of sugars needs to be done. Because pre-pregnancy, they may have a feeling that 120 fasting is okay, then 170, 200 post-lunch is okay. Those goals are not to be heeded to once they understand that they're pregnant. So patients need to have this tighter control, 90 to 100 fasting, and that's it. And if your sugars are going beyond 100, if it's 110 or so, you will need titration. You may need insulin. Sometimes just with thrice daily 500 mg metformin extended release may help good sugar control even in a diabetic pregnant patient. But when even on say 1500 mg of metformin, sugars are not controlled, then it's time to switch to insulin. Now the type of insulin depends on how the sugars have been throughout the 24 hours, and for which this particular test called CGM, continuous glucose monitoring, can help one understand. Because since you get a snapshot of how the sugars have been for 24 hours, you know at what time you need to intervene. As in, sugars are going after breakfast, after lunch. How high are they going? Are they going beyond 160? Are they touching 200? In which case, you will probably need to give 2 times, a combination of short and long-acting insulin. Like we have degludec and fiasp combination, aspart combination, which you can give. You can start off with 10 units in the morning, then 8 units in the night, and then of course watch. If people who can't afford a CGM, continuous glucose monitoring, which costs around 4,000, 5,000 in the market now, if they can't afford, then they will have to do self-monitoring of blood sugars, SMBG, if possible, 4 or 5 times a day in 24-hour period. Or if there are any symptoms, hypoglycemia symptoms, where they are sweaty, then they are getting giddiness and all, then at that point they will have to check. So at any given point, if sugars are falling, they will have to write it down at that particular point of time, and then have a discussion with their diabetologist, and then probably titrate the whatever, metformin and insulin that they're on, maybe alter it, increase or decrease it based on diabetologist's recommendation.
Okay. So before we continue further, I would like to tell our audience about our WhatsApp communities. So if you're serious about diabetes management, and or you're pregnant, or you're planning to be pregnant, please join our communities of diabetes and pregnancy. Simply drop a message in the chat saying I'm in, and we'll make sure that you get an invitation. Or else you can find the links to these communities in our bio. So, moving on. Next question would be, what dietary recommendations and lifestyle changes are important for maintaining stable blood sugar levels during pregnancy?
Yeah, another important pillar, in fact, for good sugar control in a pregnant diabetic patient is that they need to make sure they're not on any high glycemic index foods. The glycemic index means that the spike that one would get after eating food, the lower the better. So we want a plateau. We don't want a spike like a peak in sugar level. So if postprandial, after breakfast or lunch or dinner, post meal, if the sugars are going up, then you will have to probably, apart from sugar, apart from insulin and metformin, you will probably need to titrate and focus more on your diet, because just good diet can actually help you probably with 35-40%. That can help you control your sugars. In fact, there are so many patients that I know with just metformin 1000 mg, that is 500 mg morning and night, and good diet control, they had fantastic, uneventful 9 months of pregnancy. There was never a sugar spike that went beyond 150, 160 at any time of the day, and then it did not cross 95, 96, the fasting sugar. So the focus again remains that this low glycemic index foods be encouraged, as in foods that are having higher intestinal transit time. I mean, these foods should not be digested easily or assimilable easily. As in, we are trying to focus more on whole wheat, multigrain rich kind of foods where there is more fiber, more plant protein, less carbs, less fat, less easily digestible carbs. That is, a simple example would be idli versus multigrain roti without oil. So when someone has idli, for example, 3-4 idlis, then they're going to have a spike in sugar within an hour or so, which is really not the case when they're having a multigrain roti, for example, because the digestive tract takes more time to digest, and then because it takes more time, there is a slow and gradual release of sugar into the body, into the blood, rather than a spike that a high glycemic index food like idli would produce. So that is the focus. We want foods that are a little they take more time to digest. So focus more on plant protein, high fiber diet, soya, then all the dals, legumes, beans, pulses, dals. All these definitely help, because they tend to bring down the postprandial spike of sugar, and focus less on sugars in every form. Not even jaggery. People have a feeling that jaggery is better than sugar and they can take jaggery, but really that is not the case, especially in a pregnant diabetic situation. And again, milk is good if it is toned. That is 2% toned milk is good. Curd is good. They can have all kinds of soya based diet. Then chana dal, then peanuts. So plant protein basically we do recommend, because when you try to encourage dietary restrictions for diabetes, people have a feeling they're on one side they're supposed to eat for both, for the fetus and for the mom, for the mother itself. But then you have to do it in a balanced manner. You need to have good vitamins and minerals on one side, which I'm sure the obstetrician already gives. Supplements, B12, folate. B12 and folate are really important for a pregnant female, because deficiency of which can cause neural tube defects in the baby, which means the spinal cord, brain development may get hampered. So on one side, you need to have good vitamins and minerals, but on the other side, you also need to have good proteinaceous meal, thrice daily. But we tend to recommend that all the protein requirement comes from plant protein rather than non-vegetarian. But of course, it's not contraindicated in pregnancy. They can have non-vegetarian, but red meat is supposed to be discouraged as much as possible. Fish and chicken can be had. Of course, if it is not fried form, they can definitely have. And egg whites are an excellent source of protein. And of course, egg yellow also. One yellow per day can safely be taken by a pregnant female. So if you do a good titrated diet, it will definitely help you bring down the spikes, and maybe it may even help you escape the need for insulin. So but of course, this is not a statement that is a blanket statement for everyone, because some patients, because of their bodily requirements, they may require insulin eventually. But if there is a insulin requirement, it is really important that they prefer the U300, the second generation basal insulins, the U300 insulin, glargine insulin, or the degludec. Both are safe in pregnancy. They can take, and because these insulins help one from preventing hypoglycemia as well. We don't want sugars to fall. At the same time, we don't want sugars to have a spike. So that kind of a plateau kind of thing is possible with the newer second generation basal insulins on one side, metformin, of course, and of course, to the vast majority, diet definitely helps. And one other important aspect is exercise. You will need to exercise because you can do cardio, limited cardio, and probably some degree of low weight bearing exercise as well, resistance training. So exercise, diet, and these metformin insulin combinations can help one reach these intense strict goals of 90 to 100 fasting and 130 to 150 post lunch.
Okay. So one thing I would like to add to whatever you said, not in terms of the expertise because I don't know, I'm not a doctor, but for the audience, it's very important that, for instance, what Dr. Gude was talking about insulin and the choice of insulin, you guys really need to go to your doctor and talk to them, and under their supervision only you take such decisions. Never do it on your own. Because it might, result in worse, consequences. So, Dr. Gulab, what support and resources are available for pregnant women with diabetes? How can healthcare providers, family, and friends contribute to a healthy pregnancy journey for a diabetic woman?
Yeah, I think family support, friend support is really important. The entire family needs to be educated and counseled on, especially diet, what kind of diet they need to give, and then because we don't want malnutrition or undernutrition or even overnutrition. We just want a balanced diet that the patient needs to have thrice daily. So that is something I think family plays a very important part in that, and of course there is obstetrician help that diabetologists take, and then obstetricians take diabetologists help as well. It's a teamwork from healthcare provider side. But then people who can afford, I think CGM is one thing that definitely is like boon, especially in GDM. When one understands that there are spikes in sugar levels, or there is even one episode of hypoglycemia, and patients they tend to have they tend to think that sugars on the higher level, as in 120 fasting, 130 fasting is okay, rather than having sugars fall. So that kind of thinking may help one push falsely into a kind of a false reassurance where they think it is okay to have sugars on the higher side, 120, 170, rather than having sugars fall. Yes, sugars should not fall, there's no doubt, but if you are allowing sugars to be on the higher side for longer periods of time during pregnancy, there are complications that will stem both to the mother and the fetus as well. Delivery issues, then fetal malformations, macrosomia, big baby syndrome. All these are going to occur. And in fact, there are studies that say that people, babies that are born with beyond 4 kg during birth, when the babies are, when they grow up and beyond their 20-25 age, there is a higher risk of diabetes for these particular large babies as well. So it is really important that we make sure the baby's body weight remains 3.5, the optimal 3 kg, 3 to 3.5 kg, and then there should not be any complications even for mother as well. So we cannot, this kind of complacency that families also tend to think it is okay to have sugars on the little higher side, 20 more than the goals that the doctor has strictly said. That is not to be encouraged at all. And of course, nursing staff also help. There are dietitians that help, especially they are really important. And then exercise-wise, there can be trainers that can help with exercise. So literally, it is an ecosystem of both, on one side, family, friends, support group. There are pregnancy support groups as well. There are some exercise-related activities that pregnant females can participate in, then understand each other's whatever issues that they have been going through, and then bring that to healthcare providers, both obstetricians and physicians on the other side. So I think it is always a teamwork, and these support groups definitely help. And of course, there are other aspects to pregnancy, like anxiety, various other issues. But I think good reassurance, counseling, awareness can definitely help one sail through pregnancy in a healthy, safe manner.
So basically, it's a team game. Everyone has to play their part in this process. So we have two questions from our community, WhatsApp, the diabetes community. First is, in the last trimester, when the food requirements of the mother and fetus as well increase, then how to give increased portion size to the mother, keeping in mind the gestational diabetes?
Yeah. So portion size can increase slightly, definitely. It needs to increase towards the second trimester, second and third. But especially, it does not mean that taking a little higher amount of protein may increase sugar and all. So it is about what are you putting in that portion, in that plate, whatever you are going to have. It is really important that you bring down your carbs. Okay, carbs and fat on the lower side. Plant protein and fiber on the higher side. So, like we discussed, diet is really a challenging thing, especially when sugars are on the higher side and there are fluctuations within the day. Intra-day variability is high. In that case, diet makes a really important pillar of management. And so portion size can increase, but it's about what kind of food or what is the percentage of protein contributing to that wholesome diet. That matters. So protein and fiber, you can increase. Carbs and fat, you can decrease.
Okay. So if the sugar level spikes despite using medicines, is insulin injection safe? Although you have already answered it, but is insulin injection safe? Will it have any other adverse effects?
So insulin is absolutely safe. In fact, the only recommended medicine apart from metformin in pregnancy. Insulin is definitely safe. But then in insulins, we have so many types and classes: short acting, medium acting, the long acting on the other side. So we have second generation basal insulins, which are long acting, which can be combined with short acting insulin if required. Or you can just give one shot of basal long acting insulin once per day. But then giving it twice depends on how the sugars have been throughout the day, which you can find out with either self-monitored blood glucose or with continuous glucose monitoring. So once you understand at what point of time sugars are spiking, you may then titrate and decide if the patient benefits from twice daily insulin or once daily insulin. But insulin is completely safe in pregnancy.
Okay, so let me check if we have any questions from the audience. Okay, we don't. So thank you so much, Dr. Gude, for such informative answers and all the other collaborations on behalf of the media.
Thank you.
And I would like to extend my gratitude on behalf gratitude to our audience for being a part of this live session. At Tip Media, we are dedicated to delivering expert health information for your well-informed choices. Please avoid unreliable health advice on social media. Follow the Healthy Indian Project on WhatsApp and other social media platforms for trusted and reliable health updates. Remember, when you know better, you live better. Thank you so much, Dr. Gude. Good night.